Our next presenter is Dr. Carmen Polito. She's one of our faculty at mostly basic Grady, who'll be talking to us about the pre-hospital identification and management of sepsis.
All right, well, thank you to the course directors for the opportunity to speak today. I probably should say that following Craig Cooper-Smith, it's kind of like trying to hear a mouse squeak after a Metallica or a Rush concert, so we'll go with it. So the topic of the talk today is pre-hospital identification and management of sepsis. Although I am a clinical researcher in this field, I should note that I'm not formally trained in EMS or emergency medicine, and I do hold the bias that recognition of sepsis in the emergency room is just too late. So over the next 15 minutes or so, I'll try to make the case for why that might be. Here's the outline for the talk. So talking about why target the pre-hospital environment, and by pre-hospital, I'll specifically target EMS. We'll spend some of the time talking about improving pre-hospital recognition and care of sepsis, and finish up with a couple future thoughts on how we might move forward. So how many of you in the audience would consider yourselves familiar with the field of pre-hospital sepsis care, by a show of hands? Good, so I'm in the right place. This might help to understand why. So this is a histogram showing the number of pre-hospital sepsis publications that have been published over the past 25 years. And you can see the uptick really starting to turn up in the past 5 or 6 years. And this is as we, as a critical care community, have started to embrace the idea of thinking about critically ill and septic patients outside of our traditional walls of the ICU and even beyond the emergency room. So people are starting to look at this and wonder, can we improve? As we just heard, sepsis is now defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Other defining characteristics for sepsis would include it's everywhere, right? I mean, we know this, although our estimates are very broad at this point. Hopefully that will be refined in the future. It's a top killer in our country, again, with broad mortality estimates, but this is still true. To our best knowledge and evidence, treating sepsis is time sensitive, and the landmark article by Anand Kumar and others, now 10 years old, showed an 8% increased risk in mortality for every hour delay in starting antibiotics in septic patients. And finally, all of this together represents a serious public health concern that we're all interested in improving on. So if you take these defining characteristics, they could also be used to describe several other life-threatening time-sensitive conditions. These are heart attack, where time is muscle; stroke, where time is brain; cardiac arrest, where time is life or death; and of course, the golden hour in trauma. So in these situations, there are very well developed and established pre-hospital systems of care that are used to improve outcomes on the back end. And unfortunately for sepsis, this is not the case. If we were to put sepsis in the mix here, which I would argue is warranted, this might be our catchphrase: sepsis, time is organ dysfunction. So the question becomes, can we improve pre-hospital sepsis care by using existing systems that are used in STEMI, stroke, trauma, cardiac arrest, as a model to improve our framework and understanding and systems of care in sepsis? For these other conditions, the priorities are to recognize the condition in the pre-hospital setting, to activate a pre-hospital alert before the patient arrives at the hospital to mobilize resources. In some instances, giving primary treatment in the field by paramedics and EMTs, potentially triaging to specialized centers of excellence, and finally having rapid triage into the hospital so that care can find the patient instead of the patient having to find care throughout the complex hospital system. As we all know, this is our current care paradigm for sepsis. Patient hits the emergency room, someone or something alerts us that a patient might be septic, and we do a few very specific things in a short period of time to try and improve outcomes for the patient. I would propose that we could potentially expand the continuum of care, or the episode of care, even earlier into the field where paramedics are the point of first medical contact for many of our patients. This gives us the opportunity to decrease delays and process measures that patients are getting inside the hospital. So that sort of as an initial construct, but why else might we target EMS in improving sepsis care? There's a very large epidemiologic study now, a few years old, out of Seattle, King County, Washington, looking at EMS and sepsis care in particular. They found that paramedics touch many of our septic patients before they get to the hospital. So upwards of half of our patients are brought to the hospital by ambulance. And in those patients, and in that same study, they showed that EMS is touching more patients with sepsis than they are acute MI or stroke, and many more of those patients are also dying. It's also been shown in smaller studies that relying on clinical judgment by EMTs and paramedics to recognize sepsis before they reach the hospital is not reliable. So very low numbers, 10 to 30% recognition rates without any structured process for improving recognition. And at the current time, we lack good evidence and guidelines to help direct care in the pre-hospital setting. So currently there are no standardized protocols in how to approach these patients. So much room to improve. So it's a first important step. We think about how might we improve recognition? Well, there are a variety of options. Point of care diagnostic testing, both invasive and non-invasive, are things that people are working on. What about clinical screening tools? We've just heard about clinical screening tools for the hospital setting, but what about the pre-hospital environment? And also mobilizing and leveraging technology applications to help paramedics and EMTs recognize patients in the field. So this is what we're all looking for, both in the hospital and in the field, right? The pregnancy test for sepsis. We want a very easy, simple to use test that's reliable, that tells us in an instant whether we think a patient is septic or not. And again, ideally what we'd be looking for to help everyone recognize sepsis is a simple test. So anyone can use it. It's fast. We don't have to wait on cultures for days to tell us whether a patient is infected, and that's related to their organ dysfunction. It's highly sensitive, so we defend against leaving any sepsis behind. It's reasonably specific. It's generalizable to the masses. It's cost conscious, and the list goes on. Unfortunately, we don't have that at the present time. So here's one thing that others are working on. This is a group from Florida looking at non-invasive capnography and end-tidal CO2 measurement in the non-invasive route to help define in the field whether patients might be septic. This is a prospective cohort from Chris Hunter and his group looking at over 300 patients in Orange County EMS. They used a clinical screening tool that included end-tidal CO2 to help define sepsis, and looked at the characteristics of the individual components of their screening test to see how they performed. This is a receiver operating characteristic curve, and they looked at individual variables. So these are mostly vital signs: heart rate, temperature, blood pressure, et cetera, including end-tidal CO2, to see how those individual variables discriminated between septic and non-septic patients in the pre-hospital setting. Bars that are to the left-hand side of the screen are better at discriminating those patients out, and the teal line in this case is end-tidal CO2. So this was the best discriminator in his study of helping paramedics define septic versus non-septic patients. The receiver operating characteristic curve, the area under the curve here, is about 8.84. So food for thought. Others are working on clinical pre-hospital screening tools. So in this case, it is North America versus Europe. There are quite a few of them out there. The problem with these clinical screening tools, for the most part, is that many of them are clinically derived. They are not empirically derived based on data. They are validated in small sample sizes, and there are no randomized trials, cluster randomized designs looking at whether this improves outcomes. So there's a lot of work to do here, and we're just getting started. There was a recent systematic review looking at the performance of these clinical screening tools in helping paramedics recognize sepsis in the field, and some of them are pretty good. So the sensitivity overall ranged from 43% to 87%, and certainly it's much better than the sensitivity using clinical judgment by paramedics alone, 10 to 30%. So I think there's a signal here that this may be helpful, and again, this is still in its infancy, so room to grow. So 2 slides ago on the map, our group was the purple dot. So we have developed one of these pre-hospital screening tools, and this is one of the few that is empirically derived. So based on a mathematical model, we used over 500 EMS patients transported by Grady EMS to Grady Memorial Hospital a few years ago, and took a group of those patients, 80%, to develop our mathematical predictive model, and the remaining 20% of these patients to internally validate whether it was useful in a separate group of patients. We looked at 26 pre-hospital potential predictors of sepsis and found that there were 6 that were statistically significant that we retained in our final model. The most highly associated predictor in the pre-hospital setting from our study was transport from a nursing home, which I don't think anybody would be surprised to hear. So increases your odds of having sepsis by over 4.5 times. The other significant predictors included older age, which, please hold your tomatoes, in this study was defined as over 40. And other things that were predictive. So if 911 medical dispatch categorizes your complaint when you call into the medical dispatcher as a sick person complaint, that increased your odds of having sepsis. Hot tactile temperature assessment, a low systolic blood pressure, and finally a low oxygen saturation. So putting all of this together, our tool also performed reasonably well with an area under the receiver operating characteristic curve of 0.84. And when put into practice through modifying the model into a clinical screening tool, the sensitivity of that tool was about 86%. So again, I think a reasonable start, but much more work to do. Finally, people are using technology to try and help identify patients in the pre-hospital EMS setting who might have sepsis. So this is Chris Seymour out of Pittsburgh. He has developed this Think Sepsis app. It is a biotelemetry remote monitoring device that can transmit continuous streams of data from the pre-hospital environment, not just EMS, but elsewhere potentially into the hospital, again, to aid paramedics and EMTs in recognizing who might be septic. So these are just a couple things that people are working on, but again, a lot of room to grow. I'll switch gears now from talking about how we might improve recognizing sepsis in the field to how we might think about improving care for these patients in the future. Again, a variety of options. We've talked a little bit about pre-hospital alert systems. There's the potential to deliver primary treatment in the field by EMS. This is hotly debated and provocative, so we'll talk about that a little bit. And then finally, is there a benefit to transferring patients who have sepsis to specialized centers of sepsis care excellence in the future? So this is the Donabedian model. He's the father of quality improvement. This is his structure, process, outcome framework for how you might think about improving quality of care around any problem or barrier that you have. So the concept is to build a structure, which is the pre-hospital alert system in the field around sepsis. The goal of that is to speed process measures in the hospital as things currently stand, so our 3-hour bundle, our 6-hour bundle, et cetera, with the ultimate goal of improving outcomes on the back end, so more patients leaving the hospital happy, healthy, and doing well. This is something that our group is currently working on to study how our tool affects these other domains. What about primary treatment in the field for patients who are potentially septic? So this is tricky. There are a lot of considerations. The most important thing is picking the right patient. I think we would probably all agree on that. But when you get into the details, this is where the devil is, right? So what about fluids? What choice of fluids are you going to use to give patients who are potentially septic? What route are you going to administer fluids through? What amount is the correct amount? What is the right trigger? And certainly there are considerations and concerns about patients with concomitant heart failure and end-stage renal disease. So lots of details to tease out. None of this has been tested and validated as helpful for patients. But again, this is where the field is moving. Same questions apply with antibiotics in the pre-hospital setting. What is your choice? Is it going to be monotherapy? Is it going to be combo therapy? What about cultures? Hey, we'd like to have that information downstream to tailor therapy in the future. So how do we obtain those cultures before antibiotics, and how do we manage and transport those cultures into the hospital so they get to the right place? Oh, and what about that nursing home patient who might be at risk of multi-drug resistant organisms? How does that factor into our algorithm of how we treat these patients with pre-hospital antibiotics? Again, more questions and answers, so more to come. Stay tuned. Finally, what about triage to specialized centers of excellence? This is not currently the state of affairs, but it's worth asking the question, do sepsis patients treated at high volume centers do better? I mean, this has been, again, proven in other disease processes, heart attack, stroke, and trauma. So would the same concept apply in septic patients? So with that, I'll finish up a few conclusions and thoughts for the future. I would submit that our pre-hospital system of care is woefully underdeveloped at the present time, and there's much room to grow, much work to do, so stay tuned. The good news is there are many options, and there's a lot of potential for improvement, and this field, again, is in its infancy, so things are heading in the right direction. Why target the pre-hospital environment? Because sepsis is everywhere, it's life-threatening, the stakes are high, and the ED is just too late. How might we think about improving pre-hospital recognition and care? Again, a variety of options. So pick your favorite one, and we'll all go out and make a difference. So thank you for your attention, and I'd be happy to take any questions.